Hello, everyone, and welcome to today's webinar, Trauma Verification's May Q&A Web Conference. When you join today's webinar, you selected to either join by phone call or computer audio. We would prefer that you join by phone call for best sound quality. You can change your selection by accessing the audio pane in your control panel in the upper right corner of your screen. I would now like to introduce Megan Hudgens, Trauma Verification Program Coordinator. Megan?
Hey everybody, this is Megan Hudgens. I am one of the co-coordinators for the verification program, and thank you so much for joining our webinar today. And just to introduce a few of our VRC staff, Tammy Morgan, our Manager of Trauma Center Programs, is not here today, but we do have Molly Lozada in the room. She won't be presenting, but she's here as moral support. And Bumi Parikh will be handling the announcements and general questions. And Rachel Sanchez will also be coming in for some scheduling announcements. Quick disclaimer on continuing education credits. To qualify for CE, you must attend at least 50 minutes of educational content, and the email will be sent to all attendees who qualify for CE within 24 hours of the webinar ending with instructions on how to claim CE. If you have any questions at all, please email cotvrc@sacs.org. One more I have to read verbatim. What is the goal for this webinar? Interpret the standards outlined in the Resources for Optimal Care of the Injured Patient manual to ensure that hospitals have an understanding of the criteria to provide quality care to the injured patient, and understand the processes and standards involved in an ACS trauma verification site visit and how following these will positively impact the quality of care of the injured patient at your trauma center. So let's get started. So as always, we're going to recommend that you have a copy of the Resources for Optimal Care of the Injured Patient on hand. That can be in the form of a hard copy, or you can always, of course, download a PDF version. We recommend that you have this, especially for the CD-related questions section of the webinar that'll be towards the end of the presentation. And we also recommend that you use the most current clarification document and verification changelog in conjunction with the manual. These can as well be downloaded at the link at the bottom of the slide. And the clarification document and verification changelog, these are released monthly. The changelog will note any changes in the criteria and any updates. And the clarification document, of course, is elaborations on any criteria. And there are screenshots below for reference. And a few website resources for trauma centers. You can access all of our past webinars, and there are about 3 years worth of these now. It's been going on a while, so you can feel free to check out the link at the top of the slide. We also have a stakeholder public comment website for ongoing evaluations to the criteria. Please, if there are any criteria that you feel are not important or helpful, then please let us know. We do ask that you provide any evidence for any changes that you suggest, and there's more information on the second link on the page. We have a few additional tutorials. Firstly, becoming a verified trauma center first steps and becoming a verified trauma center site visit. Also, please take a look at the participant hub. One thing that I wanted to mention is that if you have not already done so, please do add contact information for your administrative contact, your CEO, COO, hospital president, or whichever hospital administrator you would like us to, at the end of your site visit, send your final report to. And also, we have an expanded FAQ for additional questions that you might have about the verification process. Quick disclaimer, all questions are pulled directly from the question submissions. There have been no edits made to the contents. If your question is not answered today, the question may require more information and will receive a response from ACS staff within 1 week of the webinar. And with that, I'm going to turn this over to Rachel for some quick scheduling reminders.
Good afternoon. For those who have already submitted their application for a site visit, thank you for your patience as I go through the next few slides regarding the scheduling process for the new participants on this call. Okay, so the site visit application is found online only, and it can be accessed on the following ACS Trauma website pages at the VRC site visit application page and also the Trauma Quality Program Participant Hub Account Center. Once you click on the links, it will take you to the Account Center page. You'll see there you could log on. Just a reminder that the login that you use would be the one that you use to access the TQIP education portal. Once you log on, you'll see the sections that you're able to access, and one being the contacts at your facility, which Megan had mentioned. That's where you can definitely go ahead and update your staff information, especially the TPM, the TMD, and your CEO. And then you can also scroll down to request a site visit there. Once you click on that, the application will drop down. And just a reminder that the online application must be submitted at least 13 to 14 months in advance of the requested site visit date and must be before the expiration date. You'll see that you can add in your exact dates, your preferred dates there. And also, if you have an alternate pathway, or if you're going to apply for an alternate pathway, just a reminder that it's for non-board certified surgeons and physicians who have trained overseas and want to participate on the trauma call schedule. Their CVs must be submitted to the COT VRC inbox as they'll need to be vetted by a subcommittee for eligibility to go through the alternate pathway. Also, you'll see on there, all level 1 trauma centers must also complete the orthopedic trauma liaison, the OTL form, which can be downloaded on the site visit application. And that form will be need to be submitted to the COT VRC inbox as well with a copy of the OTL's curriculum vitae. And at this time, we are accepting applications for the year 2020. So 2019 is now closed. Okay, so once the application has been submitted, the VRC office will provide you with an email receipt confirmation. And then after your application has been reviewed, logins to the online PRQ will be provided to the TPM within 5 to 7 business days. The online PRQ can be accessed at the following link. And also, a copy of the PRQ in Word can be downloaded from that link provided there. We ask that you do not submit payment until you receive an invoice, which you'll get approximately 60 days before the visit. And then your center will be billed annually for the trauma quality program fee. If you have any questions about the fees, there's a fee structure that's located at the link at the bottom of your slide. Also, so scheduling site visits. Visits are being scheduled quarterly. At this time, I'm working on scheduling the last quarter of 2019. And then as mentioned, we ask that you provide exact dates that you would like the visit to be scheduled on. The visit will occur on your chosen dates. However, in the slim chance a reviewer cannot review on your chosen dates, we will notify you as soon as possible for new ones. Once the review team has been secured, you will receive a confirmation email approximately 120 days prior to the scheduled visit. This will include your reviewer names and their contact information, as well as a standard review agenda. Site visit preparation with reviewers. The site reviewers will arrange for their own flights through the ACS travel agent. The reviewers will make their travel plans approximately like 20 to 30 days prior to the site visit. And we ask that the hospital arrange and pay for the site reviewers' hotel accommodations as well as their ground transportation. And we also ask that you contact reviewers directly within 30 days of the site visit for their flight itinerary, and also to give them hotel information or ground transportation information, just any logistical information that's needed to ensure for a successful visit.
And just one quick mention, this is Molly, and I'm not sure Rachel mentioned this, but we've gotten some emails and questions and calls about the logins, and just to clarify that the PRQ logins are different from the hub or the participant hub login, so they're not going to work and they're not interchangeable. So, so if you have any questions about that, feel free to email us. Thank you.
And with that, we're going to turn the presentation over to Bhumi Parikh for some announcements.
All right, hi everyone. We're going to go ahead and have some announcements. So the next verification Q&A webinar will be on Wednesday, June 26th at 11:30 a.m. Central Timing, and the deadline to submit questions will be Thursday, June 13th. And then we have some exciting news for the July 2019 webinar. So this will now be on the same platform as the TQIP webinar, but it'll be the same registration and question submission process. And then all these instructions will be sent to you via email. The main two differences will be that there's no option to call in by phone anymore. So you only have to use your headphones or speakers on the computer, and the CE eligibility has also been extended to watching the archived webinar video. So the CE eligibility will now have an expiration date, and that date will be communicated via email and on the website. So looking forward to this new platform. So we'll go ahead and get started with general questions. So we had a couple questions on the VRC monthly updates. So this was like a three-parter question. So the first question was, can any new changes be marked by a certain color for each clarification document, not just the change log? So as a reminder, if there are any updates and or changes to these documents, we usually summarize that in the narrative of the email. And then the updates and or changes are then highlighted within the respective document itself. And then as a reminder, these updates, we usually try to send them on the 15th of the month. The next question was, can the ACS COT consider putting out one clarification document per year, as which occurs with the NTDS data dictionary process? So just to clarify, the NTDS data dictionary is released yearly and as needed. So sometimes there's years that there is no revisions at all. So however, for the VRC process, we will take this into consideration, but for the time being, we'll continue to release monthly updates, since this is helpful for new patients who are preparing for the site visits. The last question regarding monthly updates was, are trauma centers mandated to meet new clarification document requirements that are published once the site visit reporting year has begun? It might not be feasible to implement certain changes during this time for various reasons. So the answer to this is, when a standard is updated or revised, an effective date is also published along with that. So if it is an immediate change, for example, the most recent change was regarding the CME standard. So we usually try to contact centers that are in their reporting year and also all other trauma centers regarding these changes. So we try not to make changes to standards, and we do not make changes to standards and expect centers that are in their reporting year to be compliant. The next question was on OTLs. So if our OTL was the same at our 2017 verification, do we need to resubmit his CV and OTL with the 2020 application request? So there was also another similar question just like that. So after the initial visit, you would not need to submit the OTL's curriculum vitae again. However, we do need you to submit the form again for the second visit, but you would only need to complete questions 1 to 3. So the next question was on case review mortality. So during the verification process, can charts from the 10 categories be duplicated and put into the mortality charts? So no, we do not want you to duplicate charts across multiple categories. So if this case resulted in a mortality, this should automatically be placed or categorized as a mortality, even if there are other categories to which it would apply to. So this was a great question. So if you had a large amount of deficiencies at your consult and more than half have been addressed before the 6-month mark, but some were unable to be addressed until a later than 6-month date, is that bad? And this was for a level 3. In preparation of a verification visit following a consultation, the center is required to demonstrate that all the deficiencies cited have been addressed within the reporting year leading up to the site visit. we understand that there can be certain deficiencies, such as PI attendance, that can be addressed immediately. However, there can be some CDs that require more time to implement, such as provider contracts, PI structure, loop closure, and etc., since these require tracking and trending over time at a minimum of 9 to 12 months of data to demonstrate compliance. So ideally, we would like to see 18 months between the consultation visit and the verification visit to ensure proper tracking and implementation. So the next question was on orthopedic metrics. So what are the specific orthopedic metrics for the ACS survey that you will be looking at, and what are their associated targets? So in regard to the orthopedic metrics listed in the VRQ, these are for trauma patients admitted during the reporting year for the following. So there are 3 types that we're pretty much looking for. So that's going to be time from patient arrival in the ED at your institution to administration of the first dose of antibiotics for patients with open fractures. So the goal is less than or equal to 60 minutes. However, it is important to note that times that are greater than 90 minutes will be cited as a weakness during the VRC review. The other metric will be the percent of patients with femoral shaft fractures within 24 hours of presentation to your ED. So the goal for this is greater than or equal to 90%, and that's going to be a recommendation. And then the last metric is time from ED arrival at your institution to operative debridement of open tibial shaft fractures. And the goal for this is less than or equal to 24 hours. So as a reminder, these are not requirements and they will not be cited as CDs. So the next question is on TAG. Is TAG a requirement in the OR or as long as they are available? So no, TAG is not a requirement. So TAG should be available at level 1 and 2 trauma centers. So just as a note, the should throughout the resources manual is essentially a recommendation and it is not perceived as a requirement. The next question was on social work. What are the requirements for social work coverage at an adult level 1 that also sees less than 100 pediatric patients per year? Another similar question was, do we need a policy that lists triggers to consult social work for pediatric trauma patients? So medical social workers should be available 24/7 in level 1 and 2 trauma centers. However, the VRC does not require they be dedicated to the trauma program. So the best practice to demonstrate commitment to the trauma program would be for the social worker to be made part of the trauma team, or at a minimum, be provided updates in regard to activities within the trauma program. So in addition, the social worker should document their evaluation in the medical record. So as a best practice, the center should probably develop a policy for when the social worker will be needed for trauma cases or patients. The triggers will be determined by the institution. If a board-certified orthopedic surgeon takes call on an ED patient, a non-board-certified surgeon performs surgery the next day. So as a means of quality control and the surgical expectation of the board-certified orthopedic surgeon, this practice would not be acceptable. The next question is on shared physician resources. If resources are shared between adult level 1 and pediatric level 1, both freestanding via tunnel, are these physicians considered in-house? So shared physician resources in combined adult level 1 and pediatric level 1 centers, such as adult trauma surgeons responding to the pediatric activations, it is acceptable and it would be considered in-house coverage. So the next question is on trauma surgeon's response. So if the ED does not notify the surgeon until 10 minutes after patient arrival, when does the clock start for the surgeon response time? The patient arrival time or the notification time? So for instance, patient arrives at noon, but the ED does not notify the surgeon until 12:10. What time is the 30-minute response time deadline? 12:30 or 12:40? So since this is for a level 3 trauma center, the response is the trauma surgeon's time would be tracked from time of notification in either of the two scenarios. So the first scenario is the patient arrived as a non-activation but determined to meet the highest level of activation criteria. So for 30-minute response time, it would be 12:40. Or the second scenario is patient arrived and did not meet trauma activation criteria but required a surgical evaluation from the trauma surgeon based on institutional criteria. Newborn admission. For a Level 1 pediatric trauma center within a Level 1 adult trauma center, what is the most appropriate way to manage the newborn of an adult maternal trauma patient with emergent delivery? Does the newborn need to be then evaluated and become a trauma patient on the pediatric trauma service? So we would want the newborn to be evaluated to rule out any potential injuries or harm. And then the service to which the newborn will be admitted should be determined by the trauma program's admission policy. Adverse events category. Is that only deaths in the SICU, unexpected return to SICU OR? The Joint Commission has more inclusive criteria. So adverse events refer specifically to a major complication that may have resulted in a death or an unexpected return to the SICU, PICU, or operating room. So if you are able to actually share the Joint Commission's definition with us on adverse events, we can present it to the VRC chairs for consideration to adopt the nomenclature. APP coverage. Can a trauma APP substitute as a trauma surgeon provider at bedside for lower level activations? This is for a Level 2. So no, the APP cannot substitute for the trauma surgeon. For the lower level of activations, the APP may act as the primary responder as long as the hospital has credentialed them to do so, and they must be current in ATLS as per CD 1186. With this said, the lower tier criteria protocol must clearly speak to this, and in addition have criteria for the type of injuries and response expectation for when the trauma surgeon is required to respond. And then all of the above must be monitored through the PIPS process to ensure that there are no delays. Burn admissions. What is the ACS stance on trauma centers that are not burn centers, keeping burns greater than 10%? So for the answer for this question, the VRC does not have requirements regarding the number of burn patients that a trauma center should admit, regardless of status as a designated burn center. So, however, for centers that do not have a separate burn service, admitting burn patients without a mechanism of injury to a non-surgical service are acceptable. We do understand that this may increase the total of non-surgical admissions. Therefore, these must be monitored through the PIPS process for appropriateness of care. Can the backup call surgeon be primary call at another facility? So no, this would not be an acceptable practice if the trauma surgeon is on primary call at an ACS verified Level 1 or 2 trauma center. Trauma surgeons who are on primary call at these centers must be dedicated to one center. So this practice may be acceptable if the trauma surgeon is on primary call at an ACS verified Level 3 trauma center, since these centers are not required to have dedicated call or a backup call schedule. So what are the rules for using the timestamps that are system Epic generated on the notes of the providers for arrival times? So this is an acceptable method of tracking provider arrival times. But as a reminder, the electronic timestamps must contemporaneously document the care of the patient. So the next question was on liaisons. Are liaisons, neurosurgeon and ortho, required to see patients for follow-up in outpatient clinic if the patient is out of network? So the answer to this is the VRC does not have requirements regarding outpatient follow-up. The next question is on locums. Can a locums neurosurgeon be the trauma liaison to the PIPS committee? So yes, this could be acceptable, although the locum neurosurgeon liaison would be required to meet the 50% or greater minimum peer review meeting attendance. The next question is on over and under triage. We had 2 questions this month regarding this. Do we need to take into account the ED treat and release when calculating the over and under triage? And a similar question was, does the ACS support a specific method to calculate over and under triage? For example, using the Krabari matrix or the need for trauma intervention metric. So the trauma program should monitor these ED cases that may possibly meet trauma criteria and were not activated. In these instances, they should be factored into the total of over and under triage. So Krabari and the need for trauma intervention metric are both valid methods of calculating over and under triage. So the VRC does not have specific requirements regarding this, but you kind of can choose whatever you want, but you should be able to measure that. So the next question is, does a level 1 PEDS require a PI coordinator, or can one be shared with the adult program? So the VRC does not have requirements with regard to the PI coordinator position. Therefore, this role may be shared as defined by the trauma program. Isolated hip fractures. Do the geriatric isolated hip fracture sets need to be reviewed at trauma peer review? These patients are not seen by trauma. So based on your admission policy, if these patients are seen and admitted to the hospitalist with a surgical evaluation by the orthopedic surgery service and later resulted in a death, these patients would be seen as a non-surgical admission. Furthermore, these death cases must be reviewed at trauma peer review meetings.
And if I can just interject for a quick moment on this, I just want to clarify that if your policy, your PI plan policy calls for the trauma medical director to review these cases before going to peer review to rule out any issues, that's perfectly acceptable, and they would not need to necessarily go to trauma peer review. However, there are some centers that do present all their death cases at trauma peer review. So again, that's going to depend on your trauma center's PI policy.
Thanks, Molly. So the next question is on physiatrist PI meetings. So if a trauma center refers patients to a freestanding rehab facility, is the trauma center required to have a physiatrist on staff and participating in the PI meetings? So the VRC does not have requirements specific to physiatrist coverage or their attendance in peer review meetings. However, the physiatrist should attend peer review meetings if any issues in care were identified. The designating authority. The Orange Book is always referencing the designating authority. Who or what is this entity? So designating authority refers to your state Department of Health or local EMS agency. They have the authority to designate trauma centers. However, the VRC does not designate trauma centers. We only verify that the center meets the standards outlined in the resources manual. What is considered an acceptable time frame for transferring a patient out? So there are no specific time requirements for transferring patients out. However, this will be based on your institution's policy. And then as per CD 4-3, all transfers must be evaluated through the PIPS process. Operating room response. For an activated trauma requiring OR, how do you measure the 1-hour window from critical result to cut time? For operating metrics of 30 or 60 minutes, it is based on arrival time and not incision time. Trauma registry. How familiar with registry should a TPM of a level 3 trauma center be? So all TPMs should be familiar with the registry so they know what data is being entered into the registry and what is reported out. Typically, the TPM oversees and directs all data validation processes. So the TPM also completes an ad hoc review of reports in specific cases. So for instance, reviewing PI cases to ensure all injuries were captured and coded correctly. So I'm going to turn this over to Megan for the CD-related questions for this month's webinar.
Hey everybody, it's Megan again. Excuse me, just playing musical chairs. All right, so let's get into the CD-related questions. First one is on CD 28 and 29 for the trauma surgeon's response. What CD and type of deficiency would there be if the trauma surgeon refuses to see pediatric trauma team activation patients? So the level was unidentified, but we are assuming that this is from a combined program that is asking what CDs are applicable if the adult trauma surgeon refuses to see the pediatric patient. If we got that wrong, please do let us know. But if that's the case, there would have to be a backup trauma surgeon who will respond to the pediatric trauma activation. The noted two type 1 CDs would be applicable as they refer to the trauma surgeon's response, adult or pediatric, to the highest or limited tier of activations. So 2H, and then the trauma surgeon's response times must be monitored through the PIPS process for undue delays as per CD 29. And here's one on interfacility transfer. Per the TQIP webinar, the VRC and NTDS definition of interfacility transfer are different. Please clarify what the difference is. So yes, this is correct. We are working on aligning the NTDS and VRC definitions in the next edition of the resources manual. As you all know, the revisions to that are ongoing. For verification purposes and completing your PRQ, we're going to say that centers that will be undergoing a consultation or re/verification visit, patients who are transferred in or out from or to another facility, whether that is a sister hospital, same health system, freestanding or satellite ED, private physician office, whichever, those are considered interfacility transfers. Here's one on limited tier activations. Is it an ACS requirement that the trauma surgeon be notified immediately of all incoming trauma patients, regardless of tier activation? Said another way, would it be appropriate for a limited tier patient to come to the ED, be evaluated by the ED physician, and then the trauma surgeon notified at the time of discovery of injury or at admission? So for limited tier, it is acceptable for the ED physician to be the initial responder. However, the institution must define criteria for when the trauma patient requires a surgical evaluation by the trauma surgeon. All must be monitored through the PIPS process, of course, to ensure that there are no delays. If a patient presents in the ED as a non-activation, the ED physician may evaluate the patient, and if the patient meets trauma criteria, then the trauma surgeon may be notified at the time of discovery of injury. And here's one on the trauma surgeon peer review meeting. A trauma surgeon works 1 to 3 shifts per month. Are they still required to have 50% or greater trauma peer review committee attendance? And this is from a level 3. Yeah, we get this one quite a bit, but the answer is yes. Regardless of the number of shifts, the trauma surgeon is required to attend the trauma peer review committee at a minimum of 50% of the time. And this can be, to expand on this a bit, this meeting requirement may be met either in person, via teleconferencing, or by video. Here's one for trauma shared responsibilities. Should trauma own the patient in the trauma bay, or is the practice of ER physicians generally taking charge acceptable? So the emergency physicians and trauma surgeons should work closely. Typically, the trauma surgeon would retain the patient since they coordinate all therapeutic decisions. And this would tie into CD 7.5. Performance of diagnostic and resuscitative procedures may be shared, especially in training institutions. These roles and responsibilities must be defined, agreed upon, and approved by the director of the trauma service. So here's one for neurosurgery response time. And this is referring back to a previous webinar that we did back in January of this year, specifically slide 42 for APPs and responding to patients bedside for emergent cases. So that one, we've taken a screenshot of it below. If neurology makes a determination of care over the phone, does this count as response time? So what we said at the time was consult by phone is not an acceptable means of meeting the neurosurgical 30-minute response criteria. The expectation is that the neurosurgeon and or resident / APPs must be available in person at bedside within 30 minutes for the injuries established by the guidelines. So to elaborate on this a bit more, the intent of this is that the TMD and liaisons for orthopedic surgery or neurosurgery develop guidelines for which types of critical and complex injuries the orthopedic / neurosurgeon will respond to in person within the 30-minute time frame. if they send the specialty resident, PA, APP, whichever, there must be guidelines for the types of injuries they are approved to respond to, and there must be clear documentation of the discussion with the surgeon specialist on the plan of care. And speaking of APPs, so we have one on APP response times, and two very similar questions. Can APPs for subspecialties end the 30-minute response time of providers coming to the patient's bedside based on facility policy? And can the ortho APP meet the requirements of ortho response to trauma activation? So the APPs for neurosurgery or orthopedic surgery, they can be the responder at bedside for the 30-minute response based on guidelines developed by the trauma program. Refer to the previous slide as we discussed. However, there must be clear documentation of discussion with the attending neurosurgeon or orthopedic surgeon on the patient's plan of care. And here's one on the orthopedic surgeon backup call system. If you have a traumatologist on call for ortho, is it acceptable for your contingency plan to have the trauma surgeon on call stabilize the injury with an attestation that they are trained to stabilize until the traumatologist is unencumbered, or they can transfer the patient to another trauma center for surgical temporization if the traumatologist is going to be delayed an established unacceptable amount of time? So the standard is that the orthopedic traumatologist must be dedicated to the center, but if not, the center must have a backup call system in place. And if the backup call system, in this case, calls for a trauma surgeon to stabilize and transfer the patient, and we'd refer you in this case to page 84 of the Orange Book, CD85, these occurrences must be monitored through the PIPS process. Here's another one for orthopedic surgery. Please clarify backup call for traumatologist. If we have two dedicated to our program, do we need a backup call schedule? And this is from a level 2. So if the two orthopedic traumatologists you mentioned are the providers for the orthopedic service, and also if they are dedicated to your trauma center, a backup call schedule would not be required. It really is either or. You either have to have dedicated orthopedic providers on staff, or there has to be a backup call schedule. And here's one for anesthesia services. For a level 2 center, CD 11.1 states that anesthesiology must be available within 30 minutes for emergency operations. CD 11.5 states that when CRNAs are used for availability requirements, the anesthesiologist must be advised, available within 30 minutes, and present at all operations. Is all referring to all emergent operations or any operations involving a trauma registry patient. So short and sweet answer on this one is that this is referring to all operations involving trauma patients. Real quick for that one. And here's a question on the ICU patient to nurse ratio. Does the CD 1166 regarding the ICU 2-to-1 nursing ratio only apply to the trauma ICU or only to trauma patients in the ICU? Or must the nursing ratio be 2-to-1 across all types of ICU care? So regarding the patient to nurse ratio of 2-to-1 for the trauma ICU or trauma patients in the ICU, the guidelines for the patient to nurse ratio is going to be set by your individual trauma center. So that really is up to what your criteria states. Here's one for hand surgery. So if a program is unable to attain a full-time call schedule for hand call, is there an acceptable alternative such as a traumatologist temporizing and transferring if beyond their scope of hand expertise, or temporizing and referring to outpatient follow-up with hand surgeon for definitive care? And this is from a level 2. So level 2 trauma centers are required to have hand surgery capabilities. This may be facilitated through a transfer agreement for implantations, but there must be a hand surgeon or a surgeon consultant that can manage the hand injury. And very important to note, we do get asked this a lot, the service is not required in-house 24/7. It is acceptable for the orthopedic traumatologist to manage hand injuries. The trauma program must, however, be able to demonstrate who is providing hand coverage when requested. So there should be a call schedule or something available for the reviewers on site at the time of the visit. And here's one for microvascular coverage. Microvascular service. If one is not available, does an appropriate transfer agreement make us compliant? So level 2 centers, to kind of follow the same vein as the previous slide, level 2 centers must have microvascular surgery capabilities. Coverage may be satisfied by having a surgeon who can use an operating microscope for nerve repair, free tissue transfer, etc. But this surgeon must respond in person. Important to note, teleconferencing or responding by phone would not be adequate when requested by the attending surgeon. This service is not required in-house 24/7, so similarly to the previous slide. The trauma program must be able to demonstrate who is providing microvascular coverage when requested. And also, transfer agreements are acceptable for complex injuries. And here's another one for, here's one for ophthalmology surgery. Regarding ophthalmology coverage, is teleophthalmology an acceptable coverage if the center has a transfer agreement in place with a level 1 center for surgical ophthalmology situations? So telemedicine, again, to follow back on the previous 2 slides, telemedicine would not be an acceptable method of consult for the subspecialty. The ophthalmology capability is not required in-house 24/7, similar to hand, similar to microvascular, but there must be a surgeon consultant available to respond in person when requested by the attending surgeon. And the trauma program must be able to demonstrate who is providing ophthalmology coverage when requested. And as per the last slide, I'm going to be saying that quite a bit, transfer agreements are acceptable for complex injuries. And here's one for advanced practice providers. ED APPs may do the initial assessment of a patient that is then found to meet activation criteria. Must they be current in ATLS? And similarly, can you confirm that APPs that work in the emergency department and respond to trauma activations must have current ATLS? So emergency medicine or trauma APPs that are clinically involved during the initial evaluation of the trauma patient and resuscitation of the trauma patient during the activation phase would be required to have current ATLS certification. So if they are interacting with the patient at that stage of their care, then yes, they would absolutely be required to have current ATLS as per CD 1186. Here's one for the trauma registrar. Do patients that stay in the ED for less than 24 hours for observation count as admitted patients towards the number per registrar? So per the requirement, CD 15.9, one full-time equivalent employee dedicated to the registry must be available to process the data capturing of the NTDS dataset for each 500 to 750 admitted, and we do want to hone in on that admitted patients annually. If the observation patients are discharged within 23 hours of arrival at the hospital, they would not count towards the dataset requirement, nor the trauma volume requirement, which, as a reminder, is CD 24. So having said this, we are currently working on changing this standard in the next edition of the resources manual. In this case, we will be removing the word admitted and modifying the dataset requirement. And any changes, of course, to the resources manual, we will disseminate as soon as we can. And moving forward to another question about the trauma registrar. Would it be appropriate for the trauma registrar of a level 3 center admitting 600 to 800 patients per year to also be the PI coordinator? So in level 3 centers, the trauma registrar may hold the position of PI coordinator, and we do get questions about the PI coordinator position quite a bit, and it's important to remind you that the VRC does not actually have any requirements regarding this role. But in this scenario, it would be advised not to have the same person in both positions, as given the volume that you indicate, it may impact the registry support staff requirement of 1 FTE for 500 to 750 trauma patients admitted. Here's one for the trauma registrar again. Are trauma registrars expected to have roles in addition to registry data entry, such as PI, injury prevention, community outreach, office duties, etc.? This is from a level 3. So in level 3 trauma centers, the trauma registrar roles are going to vary based on your patient volume at the trauma center. For level 3s, this can be pretty disparate. So, however, if the trauma registrar's role is encumbered by other duties, such as PI, such as injury prevention, and if the number of admitted patients in the registry is greater than 750, there will need to be a separate FTE in this position. Here's one on mortality review. Does the trauma medical director need to review every trauma mortality? I think we get this one quite a bit. And then similarly, do all trauma mortalities require discussion and judgments by the TMD and or peer review committee? Both of these from A level 1. So short answer to both of these is yes. All trauma-related mortalities must be systematically reviewed, and those mortalities with opportunities for improvement must be identified for peer review. So here's one on organ donations. CD 16.9 need clarification. As per the Orange Book, the percentage equals organ donors over referrals. Is the organ donor number represented only by the patients that were determined brain dead? And the referrals, do they represent all trauma deaths? And this is from A level 1. So organ donors, to kind of clarify the terms for this specific formula, organ donors in this case would represent any patients whose organs were successfully harvested. Referrals would refer to any patients who were referred for donation by the trauma center. And also, quick note about this question. So we have received some questions about how you would answer the questions regarding organ donation in the PRQ. We are working on some clarifications for this, and we will disseminate that as soon as we are able. Here's one on the injury prevention coordinator. Does level 2 designation require a dedicated full-time trauma outreach coordinator? And this is from a level 2. So the trauma center must have someone in a leadership position that has injury prevention and outreach as part of their job description. For a level 2 trauma center though, this does not need to be a full-time position. This role can be shared with the TPM as long as the prevention and outreach activities do not encumber the day-to-day TPM duties. And here's one on alcohol screening and intervention for CDs 18.3 and 18.4. We're going to have a few of these for this presentation today. ESPERT, is that a requirement if we are currently doing alcohol screening and counseling/education? And this is from a level 1. So to clarify, ESPERT as in screening, brief intervention, and referral to treatment for alcohol use. So if you are currently doing alcohol screening for at least 80% of your admitted trauma patients and doing counseling and education for patients who receive a positive screening, and that is all patients who receive a positive screening, then you will be in compliance with the requirements. And here's another one on alcohol screening and intervention. So as a level 3 trauma center, do we need to do the ESPERT intervention or just the ESPERT screening? So this is a little bit different for a level 3. So 18.3, the actual ESPERT evaluating 80% for alcohol use, that is still required for level 3. While ESPERT intervention is of course encouraged in level 3 trauma centers, this would only be a requirement for level 1 and 2 trauma centers. However, as we said, all trauma centers of all levels must still conduct an ESPERT screening on at least 80% of your admitted trauma patients. Here's another one on alcohol screening and intervention. My question for the next webinar has to do with the substance abuse screenings for 80% of patients admitted over 24 hours. We are a level 3 center. Is the requirement really for all those patients to receive either a urine or blood test, or can we just do an audit on everyone and ask the question if they drink or abuse substances? Concerns were raised at trauma committee about the charges incurred for all of these, mostly elderly, fall patients, and if there would be pushback from Medicare or Medicaid. So we totally do understand and we acknowledge the cost to doing a urine and blood test on every patient. If you will notice in the PRQ, we do actually have a checklist of different options for how you can conduct this screening. If any of those don't apply, there's blood, there's audit, there's consumption questions, and then there's a section for other. If there's another means through which you are doing that screening, but the VRC does not mandate a particular mechanism for conducting substance abuse screening. Audit questions, as you've described above, would be completely acceptable as a method of screening. And here's one on research alternate pathway. Alternate pathway for research for level 1 center. If a TMD from another state moves to our facility to become TMD and had been a member of their state COT prior to moving, would we be able to count this leadership towards the alternate pathway for research for our center? So no, unfortunately, this would not qualify for the alternate pathway. As with the research criteria, the publications or leadership engagement must be a result of the current program seeking verification. So you couldn't have a TMD that joined your staff apply research done at a previous center to your research requirement. And to wrap us up today, we do have some questions on CME. The CME requirement, is it correct that if our trauma panel physicians are board certified, board eligible, we do not need to have their CME at the time of review, including our liaisons, only need CME for the TMD? So we would advise at the time of your site visit, having proof of the trauma panel physician's board certifications available and with their current expiration dates. You must have CME documentation available on site for the TMD and the alternate pathway physicians. Both of these would be 36 hours over 3 years or an average of 12 hours per year. And additionally, as per CD 524, the TPM must demonstrate evidence of at least 12 hours per year, and again, that's 36 hours over 3 years, of trauma-related CE. And last question of the day, we just have a quick clarification on the April webinar. Does a level 1 peds and level 1 adults both need separate full-time injury prevention, i.e. 2 people? So the injury prevention coordinator is not required to be full-time. This position may be shared between a combined adult level 1 or 2 program and a level 1 or 2 pediatric program. In level 1 trauma centers, this position must be separate from the trauma program manager's position. And that's it for our webinar today. Thank you all so much for participating, and see you next month.
We're going to hand it back over to Kat to close us out for today.
Thank you, Trauma Verification staff, and thank you everyone for attending today's webinar, Trauma Verification's May Q&A web conference. If you have any other questions, please contact the COT VRC at facs.org. On behalf of Trauma Verification and our presenters, thank you for joining us today and have a great rest of your day.